Welcome, curious minds, to another deep dive. Today we're plunging into, well, one of the most critical and frankly fascinating regions of the human body, the thorax. You might know it simply as your chest, maybe the rib cage, but by the end of this deep dive, I think you'll have a completely new appreciation for what's really happening under the hood.
Mm.
It's far more than just, a protective cage. It's this bustling, intricate hub of vital organs and structures. Our mission today is to unpack its remarkable anatomy, its surprising functions, and the incredible range of conditions that can affect this central chamber, from really common issues to rare congenital anomalies and the latest truly revolutionary surgical interventions.
Yeah, and what's truly remarkable about the thorax is that it's not just about providing a safe haven, although, it excels at that. It's absolutely fundamental for our most basic life functions, like generating that negative inspiratory force that pulls air into our lungs for breathing. And also the positive expiratory force we need for vocalization. Everything from talking to singing, basically. Its sheer complexity and dynamic nature make it an incredible area to explore. And understanding this core part of our anatomy is, well, it's key to appreciating so much of human health and how our bodies truly work in unison.
Okay, so prepare yourselves for a journey that I think will genuinely transform your understanding of something you do every second of every day without even thinking about it. From the very first gulp of air you take to the steady beat of your heart, it's all housed and orchestrated within this incredible structure. Let's start unpacking.
The thorax, an engineering marvel.
All right, let's begin at the beginning. When we talk about the thorax, what exactly are we defining? And what is it about its basic structure that makes it so profoundly critical to our survival?
Right. So the term thorax, it defines the area nestled between the neck and the abdomen. It's encased by this, well, meticulously designed framework. The ribs, the sternum, that's your breastbone, and the thoracic vertebrae in your spine. Its primary overarching function, like you said, is to support and protect all the internal thoracic organs, your heart and lungs, which are absolutely paramount to life. But it's also a dynamic structure, not just a static shield. It generates that crucial negative inspiratory force that starts breathing, essentially pulling air into the lungs. And just as important, it generates the positive expiratory force we need for things like vocalization, talking, singing, shouting. It truly acts as a central frame, connecting the neck, upper extremities, and even parts of the abdomen. It's kind of the central chassis of the upper body.
It sounds like a beautifully engineered citadel, almost. A real protective marvel. Could you elaborate a bit more on the bony thorax itself? What are its key components and maybe some of the more surprising details?
Absolutely. Yeah. The bony thorax consists of 12 pairs of ribs. They extend peripherally from the vertebrae at the back to the sternum or the costal arch at the front. Now what's interesting are the variations in how they attach. The 11th and 12th ribs, sometimes called floating rib.
Floating ribs, yeah.
Exactly. They don't actually attach directly to the sternum at all. They only connect to the spine.
Mm-hmm.
But ribs 1 to 5, they have direct attachments to the sternum via strong costal cartilages, providing a more rigid front structure. Then the lower ribs, 6 through 10, they sort of merge into the costal arch, forming a more flexible border down below. Now, if we look closely at the first rib, it's particularly flat and dense. It's a tough one.
Okay.
It travels from the first thoracic vertebra to the manubrium, which is the upper part of the sternum. And together, they form this relatively small but incredibly vital opening called the thoracic inlet.
So this small opening, the thoracic inlet, it's a major thoroughfare then. What makes such a compact area so critical? Is it just the sheer number of essential things passing through, or is there something else about its design?
That's a great question. And yes, it's absolutely a critical passageway. A whole host of essential structures squeeze through there. The great vessels carrying blood to and from your head and arms, the trachea or windpipe, the esophagus for food, and this intricate network of nerves that supply the upper extremity, the diaphragm, your main breathing muscle, and the larynx, your voice box. This is precisely why a first rib fracture is so significant. It's not just, a broken bone.
Right.
It indicates a really substantial mechanical force was applied. It takes a lot to break that rib. So injury to one or more of these vital structures packed into that dense protected area becomes highly probable. You've also got other important things in there, like the phrenic nerve controlling the diaphragm and the recurrent laryngeal nerve.
The recurrent laryngeal nerve. That has a weird path, doesn't it?
It does. It loops around the aorta on the left and the innominate artery on the right to get back up to the vocal cords. Fascinating anatomy. And the thoracic duct, a major lymphatic vessel, also inserts right around there, which is crucial for fluid drainage.
And what about the sternum, that flat bone right in the middle of our chest? It seems like a very central landmark.
The sternum is indeed a flat bone, typically, about 6 to 8 inches long, maybe half an inch thick. It comprises 3 parts: the manubrium at the top, the body in the middle, and the xiphoid process in the very bottom, that little pointy bit. The manubrium connects, or articulates, with your collarbones and the first rib. A key superficial landmark we often use, one you can probably feel on yourself, is the angle of Louis.
The angle of Louis.
Yeah, this is where the manubrium joins the body of the sternum. And this landmark conveniently corresponds to the anterior aspect of the second rib, and crucially, the level of the carina.
The carina being where the windpipe splits.
Exactly, where the trachea bifurcates or splits into the 2 main bronchi leading to each lung. This anatomical relationship, combined with the flexible cartilaginous attachments of the true ribs and the intercostal muscles between them, allows for that dynamic movement of the ribs we see with respiration, expansion, and contraction.
So it sounds like it's definitely not just a collection of rigid bones. There's movement, there's flexibility. What other components contribute to this chest's dynamic nature and its vital functions?
That's exactly right. The bony thorax is beautifully complemented by 3 main groups of muscles that enable its movement. First, you have the primary muscles for respiration. The diaphragm, that big dome-shaped muscle beneath your lungs.
The main workhorse.
The main workhorse, yes. And the intercostal muscles, the ones between your ribs. These handle your quiet, everyday breathing. Then there are secondary muscles, like the sternocleidomastoid in your neck and the serratus posterior muscles in your back. These guys chip in, they assist in breathing, especially when you need more air, say, when you're exercising vigorously.
Right, like when you're really gasping for breath.
Exactly. But here's what's truly fascinating: the body's adaptability. A third group of muscles, ones that primarily attach the upper extremity to the body, like the pectoralis major, your chest muscle, and the latissimus dorsi, your big back muscle.
Muscles we think of for moving our arms.
Precisely. They can actually form a tertiary system for ventilatory assistance in cases of severe respiratory distress. They do this by fixing the upper extremities. Imagine leaning forward with your hands on your knees when you're out of breath.
Ah, the classic pose.
That pose. It allows other muscles to pull on the rib cage more effectively, essentially leveraging your arms to help lift your chest. It just highlights how the body can recruit seemingly unrelated structures to maintain vital functions when it's under stress.
That's incredible. The body really does find a way to adapt and recruit muscles for breathing. But what happens when even those tertiary systems start to fail? Are there limits to this adaptability?
Unfortunately, yes, there are definitely limits. When even those powerful accessory muscles are struggling, that's often when we see patients in severe respiratory distress. That's when medical intervention becomes absolutely necessary. It really highlights the delicate balance of our respiratory system.
Okay. And then there's the pleura, the slippery linings around the lungs. How do they contribute to this intricate system? They sound important for movement.
They are crucial. The pleuras are these thin, serous membranes that play a vital role in allowing your lungs to move freely within the chest. You have the parietal pleura, which lines the inside of the chest wall, the mediastinum, the central space, and the top of the diaphragm. Then there's the visceral pleura, which directly covers the lung surfaces and even dips down into the fissures that separate the lung lobes. These 2 layers are separated by just a tiny amount of pleural fluid, just enough to allow for nearly frictionless movement during respiration.
Like 2 wet glass plates sliding over each other.
Exactly like that. It's incredibly smooth, allowing your lungs to expand and contract within the chest cavity without rubbing or sticking. This is why the space between them is often called a potential space. Under normal conditions, it's barely there.
But potential implies it can become a space, right?
Precisely. This potential space can become a real problematic space if it fills with excess fluid or blood or air or even tumor or infection. When that happens, it can compress the lungs, making it hard to breathe, or even compress the heart.
That makes perfect sense for smooth movement. Now, what about the blood and nerve supply to these structures? Does that explain why some procedures involving the pleura can be, well, notoriously painful, like putting in a chest tube?
That's an excellent question. And yes, it absolutely does. It comes down to the nerve supply. The parietal pleura, the lining on the chest wall side, gets its blood supply from systemic arteries and veins, like the intercostal and internal mammary arteries. The visceral pleura, covering the lung, has a dual blood supply from both systemic bronchial arteries and the pulmonary circulation. But here's the key for pain. The parietal pleura is richly supplied with sensory nerve endings from the intercostal nerves. It's highly sensitive.
Ah, so that's the sensitive layer.
That's the one. That's why, for procedures like chest tube insertion, generous local anesthesia is absolutely essential. You're numbing those highly sensitive nerve endings in the parietal pleura. The visceral pleura, on the other hand, the one covering the lung, is innervated by vagal and sympathetic branches, and it doesn't have the same kind of pain sensitivity. So while the lungs themselves don't really feel pain in that sharp way, their outer lining, the parietal pleura, certainly does. And we shouldn't forget the lymphatic vessels throughout the lung and pleura playing a crucial role in draining that pleural fluid, helping keep that potential space clear.
Inside the lungs, from tiny alveoli to major challenges.
Okay, that gives us a fantastic foundational understanding of the protective chamber, our thoracic citadel. Now let's talk about the lungs themselves, at the very core of our breathing system, the engines of respiration.
The lungs truly are a marvel of biological development and engineering. It's incredible when you think about it. Lung development starts incredibly early, maybe around 21 to 28 days after conception, and remarkably, it continues well after birth. What's truly fascinating is the sheer proliferation of these tiny structures, the alveoli. These are the little air sacs where gas exchange actually happens. We're born with approximately 20 million of them.
20 million, wow.
Yeah, but by about age 10, that number explodes to around 300 million. After that, there's no significant increase in the number, though they can still grow a bit in size. This massive increase in surface area is where the magic of gas exchange occurs, efficiently transferring oxygen into the blood and carbon dioxide out. And think about the airways. There's something like 23 generations of bronchi, those branching tubes between the trachea and the terminal alveoli. It's an incredibly intricate internal branching system designed for optimal air delivery deep into the lungs.
And these lungs aren't just big, sort of amorphous sacs, right? They have a very specific internal architecture, a defined structure.
That's absolutely correct. They are meticulously organized. The right lung has 3 lobes, the upper, middle, and lower. These are separated by 2 fissures, the major or oblique fissure and the minor or horizontal fissure. The left lung, which is slightly smaller to make room for the heart.
Accommodating the heart.
Exactly. It has just 2 lobes, the upper and the lower, separated by a single oblique fissure. Interestingly, there's a little ton-like part of the left upper lobe called the lingula, which embryologically corresponds to the right middle lobe. It's like a remnant. What's even more remarkable, organizationally, is the further subdivision into bronchopulmonary segments.
Bronchopulmonary segments. Okay, what are those?
Think of them as distinct functional units within each lobe. There are typically 10 on the right side and 8 on the left, and each segment is fascinatingly anatomically separate. It has its own artery, its own vein, and its own bronchial supply. This internal organization is what allows for very precise and localized surgical interventions if needed. Surgeons can sometimes remove just a single problematic segment rather than taking out an entire lobe, preserving more lung function.
That's incredible precision, and their blood supply must be incredibly robust given their function. But you mentioned a dual system earlier. How does that work exactly?
It is robust, and it's cleverly twofold. First, you have the pulmonary circulation. Unoxygenated blood from the right ventricle of your heart is pumped into the pulmonary artery, which then branches to each lung for oxygenation in the alveoli. Once it's oxygenated, this blood returns to the left atrium via the pulmonary veins, ready to be pumped out to the rest of the body. That's the main gas exchange circuit. But then there's a second system. The bronchi themselves, the airways, need their own nourishment. They receive their oxygenated blood supply from bronchial arteries. These arise directly from the systemic circulation, usually from the superior thoracic aorta or the aortic arch. So you have this dual system for different needs. One massive system for the vital gas exchange function of the alveoli, and a smaller one for the metabolic needs of the airways themselves.
Now, sometimes things don't develop quite as planned during gestation, leading to some truly unique, though thankfully rare, congenital conditions. Can you shed some light on those?
Yes, congenital lung abnormalities. Though rare, we're talking maybe 1 in 10,000 to 35,000 births for the cystic lesions. They really reveal a lot about the intricate processes of lung embryogenesis, how things are supposed to form. For instance, we see conditions like unilateral agenesis, where one lung is entirely absent. This is actually more common on the left side, with about a 2-to-1 male to female ratio. Or you might see hypoplasia, which is an underdevelopment or incomplete growth of the lungs. This This is often linked to conditions that compress the lung during development, like a Bachdelic hernia.
A Bachdelic hernia. What's that?
That's where abdominal contents, like intestines, protrude through a defect in the diaphragm up into the chest cavity during fetal development. This physically restricts the lung's ability to grow and develop properly, leading to hypoplasia.
So these are often about interference during that crucial developmental process. What about the cystic lesions you mentioned? Those sound like quite a challenge.
Cystic lesions are a significant group, yeah. One of the most common is CPAMs, or congenital pulmonary airway malformations. They used to be called adenomatoid malformations, a bit of a mouthful. These basically result from abnormal branching of the developing airway tree. Instead of forming normal lung tissue, it leaves behind these abnormal, often fluid-filled cysts. Type 1 is the most common, making up 60–70% of cases. It forms single or multiple cysts that are larger than 2 centimeters. If you were to look at the affected lung tissue, it can have a characteristic Swiss cheese appearance because of all the pockets of fluid, and it feels sort of rubbery.
And is there anything particularly concerning about these CPAMs beyond just being abnormal tissue?
Well, most are benign, but there's a critical point here, especially with type 4 CPAMs. This particular type has shown a strong association with malignancy, specifically a rare and aggressive childhood cancer called pleuropulmonary So while many CPAMs are just developmental oddities, this specific type carries a serious risk that means we need to be very vigilant and monitor them closely, or often recommend resection.
And then there's something called bronchopulmonary sequestration, which sounds like lung tissue that's kind of gone rogue or is completely independent from the rest.
It's a fascinating anomaly, truly. Bronchopulmonary sequestration, or BPS, is where a piece of embryonic lung tissue essentially separates from the normal tracheobronchial tree, the normal airway system. And here's the really weird part. It gets its blood supply from an anomalous systemic artery, often directly from the aorta, the main artery of the body, rather than from the pulmonary artery like normal lung tissue.
So it's getting blood from the wrong source.
Exactly. It's like it's plugged into the wrong plumbing. There are 2 main types. Intralobar sequestration occurs within a normal lung lobe, usually the lower lobes, and it's pretty evenly distributed between right and left. Extralobar sequestration is entirely enclosed by its own pleura, its own separate lining, and it's primarily found on the left side in about 2/3 of cases. We even see hybrid BPS-CPAM lesions which show features of both conditions.
How are these usually managed?
For symptomatic infants, or if the lesions are large, surgical excision is usually the treatment. Although, for smaller asymptomatic BPS, sometimes embolization of that anomalous feeding artery is an emerging, less invasive option. They basically block off the abnormal blood supply.
Another condition often treated surgically is congenital lobar emphysema. What's the mechanism there, and how quickly does it usually manifest?
Right. Congenital lobar emphysema is actually the most commonly resected congenital cystic lesion, making up about half of the cases needing surgery. Its cause is often thought to be a ball valve mechanism in the bronchus leading to that lobe. Air can get in during inspiration, but it gets trapped during expiration, like a one-way valve.
Air goes in, but can't get out.
Exactly. This leads to rapidly progressive air trapping and overdistension or overinflation of the affected lobe. This typically causes severe respiratory distress very soon after birth. It's an urgent situation because that overinflated lobe can compress the healthy lung tissue and even shift the heart.
And we also see abnormalities of the trachea itself, the windpipe, and major vessels, not just the lung tissue. It sounds like these could create an anatomical chokehold for these infants.
Indeed. Congenital tracheal abnormalities can be quite serious. Bronchial atresia, for instance, is the second most frequent congenital pulmonary lesion after tracheoesophageal fistula. Here, a bronchus basically ends blindly. The lung tissue beyond the blockage expands and becomes emphysematous because air can still sneak in through collateral airways, but with no normal exit, it gets trapped. Sometimes this leads to a mucosal, a mucus-filled sac. Tracheal stenosis, a narrowing of the windpipe, is also rare but serious. It's often characterized by complete circular tracheal rings instead of the normal C-shaped rings with a soft back wall.
Complete rings, so the trachea can't expand.
Exactly. It makes it rigid and narrow. Sometimes it's associated with something called a pulmonary artery sling. This is where an anomalous left pulmonary artery takes a weird course, passing between the trachea and the esophagus, causing compression, almost literally squeezing the windpipe and food pipe.
That sounds incredibly dangerous for a newborn. What about other vascular issues that affect the thorax?
Yes, exactly. We also encounter pulmonary arteriovenous malformations, or AVMs. These are direct connections between a pulmonary artery and a pulmonary vein, completely bypassing the normal capillary bed where gas exchange happens. This results in a significant right-to-left shunt, meaning unoxygenated blood gets directly mixed with oxygenated blood heading back to the body.
What kind of problems does that cause?
It can lead to symptoms like shortness of breath, low oxygen levels, and paradoxically, even brain abscesses or strokes, because small clots or bacteria that would normally be filtered by the lung capillaries can pass directly into the systemic circulation. About a third of these patients also have hereditary hemorrhagic telangiectasia, HHT, a genetic disorder affecting blood vessels throughout the body. Then there are vascular rings. These are fascinating and often critical anomalies where major blood vessels form a complete or nearly complete ring around both the trachea and the esophagus.
A ring of blood vessels squeezing the airway and food pipe.
Precisely. The most common type is a double aortic arch, accounting for about 60% of these cases. Here, the aorta, the body's largest artery, actually splits into two arches that encircle the trachea and esophagus before joining back together. This can cause significant constriction and symptoms like wheezing, stridor, that high-pitched breathing sound, and dysphagia or difficulty swallowing. Luckily, simple surgical division of the smaller arch is often curative.
Wow. Okay, from these fascinating but thankfully rare congenital anomalies, we need to shift gears now.
Yeah.
We have to talk about a challenge that affects millions globally and remains one of the most devastating diseases. Lung cancer. The numbers here, unfortunately, are truly staggering, impacting so many lives.
They really are. Lung cancer remains a colossal global health problem. In the United States, it's unequivocally the leading cause of cancer death in both men and women. It surpasses the combined total deaths from breast, prostate, and colorectal cancers. And this has been the case for women since way back in 1987. Despite a general decline in mortality rates over the last decade, roughly 3% per year in men, 2% per year in women, the overall burden is still immense. And what's particularly concerning are the disparities. African American men continue to face both the highest incidence and highest death rates from lung and bronchus cancer, highlighting persistent health equity issues we need to address.
And beyond the sheer numbers, what are the primary drivers, the risk factors for this disease? Is it just smoking, or is it more complex than that?
Unequivocally, cigarette smoking is the number one most important risk factor. It accounts for the vast majority of cases, something like 85–90%. However, it's definitely not the only factor. Environmental radon gas exposure is estimated to be the second most important risk factor.
Radon gas, how does that work?
Radon is a natural radioactive gas. It's released from the normal decay of uranium in soil and rocks. It can seep into homes and buildings, especially basements, and accumulate to dangerous levels. It's estimated to contribute to around 18,000 lung cancer deaths a year in the U.S. alone. Other significant factors include occupational exposures like asbestos, arsenic, chromium, nickel.
Right, industrial exposures.
Yes, and also things like air pollution and even secondhand smoke exposure. So while quitting smoking is absolutely paramount, these environmental and occupational exposures also play a critical, often underestimated role.
Given the complexity of the disease, how do clinicians even begin to classify it when they look at it under a microscope? How do they tell the different types apart?
That's where pathology comes in, and it's a field that's evolved incredibly, becoming much more precise. The 2015 World Health Organization, WHO, classification for lung tumors really expanded the use of immunohistochemistry.
Immunohistochemistry.
Yeah, it uses specific antibodies to identify particular proteins within the cancer cells. It helps pinpoint the exact cell type. The WHO classification also recommended genetic characterization for more precise subtyping. This allows for a much more accurate and clinically relevant understanding of each specific tumor, which is crucial for guiding treatment. The major types of malignant lung tumors are broadly grouped into adenocarcinomas, squamous cell carcinomas, SCCs, large cell carcinomas, and neuroendocrine tumors. Each has its own unique characteristics and behaviors.
Can you walk us through those major types? Let's start with adenocarcinoma, which you said is the most common now.
Right. Adenocarcinoma is now the most frequent histological type, accounting for maybe 45% of all lung cancers. These are malignant epithelial tumors that show glandular differentiation, meaning they try to form glands or they produce mucin, which is like mucus. They tend to occur more peripherally in the lung, further out from the main airways, in about 3/4 of cases. Critically, they have a tendency for earlier metastasis, particularly to the central nervous system. They can spread to the brain relatively early in the disease course.
And the way pathologists classify them has changed recently.
Yes, significantly. The pathology has been refined to get rid of some older, broader terms like bronchial-alveolar carcinoma, which wasn't very specific. Instead, we now have more precise classifications like adenocarcinoma in situ, AIS. This refers to tumors with a pure lipidic growth pattern.
Lipidic growth, what does that mean?
It means the cancer cells are just growing along the existing structures of the alveoli, like wallpaper, without actually invading the underlying tissue. These are non-invasive tumors. Then there's minimally invasive adenocarcinoma, MIA. This also has a predominantly lipidic pattern, but shows a very small focus of invasion, less than 5 millimeters. This refinement is absolutely crucial because it helps guide treatment strategies. For these less aggressive forms, the goal is often to preserve more lung tissue, maybe doing a smaller resection instead of removing a whole lobe. That's a massive leap forward for patient quality of life.
Okay, that makes sense. And what about squamous cell carcinoma? How does that differ?
Squamous cell carcinoma, SCC, accounts for maybe 30% of lung cancers, and it's very strongly linked to smoking. Over 90% of these cases occur in cigarette smokers. Unlike adenocarcinoma, about 2/3 of SCCs are centrally located, arising in the larger bronchi. They often expand against the bronchus, causing extrinsic compression, like squeezing the airway from the outside. They're also more prone to central necrosis, meaning the center of the tumor can die off, and they tend to metastasize a bit later than adenocarcinomas. Microscopically, pathologists look for features like keratinization, a kind of cellular tufting and intercellular bridges between the cells.
Then there's small cell lung cancer, which I understand is particularly aggressive. That one has a bad reputation, right?
You're absolutely right. Small cell lung cancer, SCLC, represents roughly 20% of all lung cancers, and it is highly aggressive. It often arises centrally, in about 80% of cases, originating in the larger airways. Critically, it has a strong tendency to spread very early to mediastinal lymph node, those nodes in the center of the chest, and also to distant sites, especially the bone marrow and the brain. Given its aggressive nature and tendency to spread early, the primary treatment is generally chemoradiotherapy, a combination of chemotherapy and radiation. Surgery usually doesn't play a major role. Even with aggressive treatment, the 5-year survival rate is unfortunately quite low, only about 5%, which really highlights its challenging prognosis. However, for a very small, carefully selected group of patients with very early-stage disease found incidentally, surgical resection might be considered as part of a combined approach, but thorough staging is absolutely paramount.
Given the often silent nature of lung cancer, where symptoms might only appear quite late, screening seems like it could be a real game changer. What's the latest on that front, and who is it actually for?
It absolutely is a game changer. Screening offers a real promise of catching this disease early when it's much more treatable. The landmark National Lung Screening Trial, NLST, which was a massive randomized multicenter study in the U.S. involving over 53,000 asymptomatic high-risk smokers. That trial fundamentally changed the landscape.
High-risk smokers, how do they define that?
Participants were aged 55 to 74, and they had at least a 30-pack year smoking history. That means, for example, smoking 1 pack a day for 30 years, or 2 packs a day for 15 years, and so on. They either had to be current smokers or had quit within the previous 15 years. The trial conclusively showed that annual low-dose helical CT screening, compared to just doing standard chest x-rays, significantly reduced lung cancer-specific mortality by 20%.
20% reduction in deaths, that's huge.
It's huge. And it also reduced all-cause mortality, deaths from any reason, by 7%. The benefit was so clear and statistically significant that the study was actually stopped early. More recently, the European Nelson trial, another large-scale study, confirmed these findings, showing a 26% reduction in lung cancer deaths in men and an even larger reduction in women after 10 years of follow-up with CT screening.
So this is clearly beneficial for the right people, but who exactly are the right people? Is this screening recommended for everyone?
That's a really important question because no, it's not for everyone. It's targeted at those at highest risk. The current National Comprehensive Cancer Network, NCCN recommendations suggest low-dose helical CT screening for individuals aged 55 to 74 who have that 30-pack year history and are either current smokers or quit within the last 15 years. It also includes a slightly broader group, Individuals aged 50 or older with at least a 20-pack year history and at least one additional risk factor that pushes their calculated risk above a certain threshold, like family history, radon exposure, occupational exposure. But it is absolutely crucial to emphasize that screening is not an alternative to smoking cessation. Quitting smoking remains the single most important thing someone can do to prevent lung cancer.
Right. Screening finds it early, quitting prevents it in the first place.
Exactly. And physicians are encouraged to have a really thorough discussion with patients about the risks and benefits of screening. This includes the potential for finding nodules that turn out to be benign, which can cause anxiety and lead to further tests or procedures, what we call false positives or overdiagnosis. It's a shared decision-making process. But the key insight here is undeniable. For high-risk individuals, this screening can literally catch cancer early enough to save lives.
Okay, so once lung cancer is suspected, maybe from screening or symptoms, how do clinicians pinpoint the problem and then plan the treatment? Diagnosis and staging sound like incredibly intricate processes, almost like a detective story, putting the pieces together.
They really are, and diagnosis can be quite challenging because, as you know, many benign conditions like infections or inflammation can look very similar to lung cancer on imaging. The physical exam is still important. For example, feeling for enlarged supraclavicular lymph nodes, those ones in the hollows above your collarbones. If those are involved, it usually indicates advanced M3 disease, which would typically mean surgery is off the table as the primary treatment. We also look for signs of paraneoplastic syndromes.
Paraneoplastic syndromes, what are those?
These are fascinating, almost mysterious, distant manifestations caused by the tumor-producing biological substances, like hormones or antibodies, not by the direct spread metastasis of the cancer itself. For example, small cell lung cancer is notorious for causing various neurological paraneoplastic syndromes that can affect the brain, nerves, or muscles, sometimes even before the lung cancer itself is diagnosed.
Wow, and what about that first step in imaging, if there's a suspected mass or maybe a nodule found incidentally on a scan?
The workup often begins with a solitary pulmonary nodule, or SPN, which is usually just a small spot found incidentally on a chest X-ray, or, more commonly now, a CT scan. Evaluating an SPN involves a combination of imaging, usually a detailed CT scan and often a PT-CT scan as well. A tissue biopsy is frequently needed to confirm if it's malignant. However, it's worth noting that if an SPN is entirely calcified, meaning it has significant calcium deposits throughout, or if it's unstable and unchanged on CT scans for 2 or more years, it's very likely benign and might not require an invasive biopsy. And before any planned lung resection, surgery to remove part of the lung, bronchoscopy is essential.
Bronchoscopy, putting a camera down the airway.
Exactly. A flexible tube with a camera goes down the windpipe. It allows the surgeon to directly visualize the airways, assess the endobronchial anatomy near the tumor, clear out any secretions, and importantly, rule out any unexpected secondary tumors or synchronous cancers within the airways.
So once you have a diagnosis, how is the extent of the disease actually determined? Staging must be absolutely critical for treatment decisions, like creating a roadmap.
Staging is absolutely critical. It is the roadmap to treatment. The system used worldwide is the American Joint Committee on Cancer, AJCC, and the Union for International Cancer Control's TNM classification. We're currently using the 8th edition. TNM stands for Tumor Nodes Metastasis. It provides a precise, standardized description of the cancer's extent based on the size and invasiveness of the primary tumor, T, the involvement of regional lymph nodes, N, and the presence of distant metastasis, M. This system is what guides the initial treatment recommendations and helps doctors evaluate outcomes and prognosis. The big picture takeaway is that this detailed system allows for an unprecedented level of precision in tailoring treatment to the individual patient.
Let's delve into the T stage, which describes the primary tumor. You mentioned it has evolved significantly, becoming more detailed. What's the big picture takeaway here for someone listening? Does this hypergranularity fundamentally change how lung cancer is approached now?
That's an excellent question. The T stage has indeed become incredibly precise. Instead of just thinking small or large, we now have very specific size categories, some even breaking it down into sub-centimeter measurements. For example, tumors under 1 centimeter, T1A, are now specifically categorized separately from those 1 to 2 centimeter, T1B, or 2 to 3 centimeters, T1C. This helps us tailor treatment with much greater accuracy. And importantly, for the first time, this 8th edition includes specific definitions for carcinoma in situ, those non-invasive tumors with the pure lipidic growth pattern we talked about.
Right, the wallpaper tumors.
Exactly. And also minimally invasive adenocarcinoma, T1MI, which has that predominant lipidic pattern but very limited invasion, less than 5 millimeters. The key insight, the big picture takeaway, is that this level of precision allows us to be far less aggressive in treating some of these very early stage cancers. For these in situ or minimally invasive forms, we can now seriously consider treatments that preserve much more lung tissue, like a segmentectomy or even a wedge resection instead of a full lobectomy. This is a massive leap forward for patient quality of life and long-term breathing function, moving away from a one-size-fits-all surgical approach for all small tumors. Of course, other T-stage determinants still include invasion of specific structures. For example, if the tumor invades the visceral pleura, the lungs covering, it bumps it up to at least T2. Invasion of the chest wall or the phrenic nerve makes it T3. And invasion of critical structures like the heart, great vessels, or trachea makes it T4. CT scans, and sometimes MRI, are crucial for determining this T stage accurately, especially for complex cases like those Pancoast tumors involving the chest wall.
Okay, that clarifies the T stage. Now, the end stage, nodal involvement, sounds like it's equally complex and really critical for prognosis and treatment planning. How do doctors assess that, and why is it so important?
It's extremely critical, yes. Lymph node involvement directly impacts both prognosis and the recommended treatment path. Mediastinal lymph node metastases nodes in the center of the chest are unfortunately found in a significant proportion of patients at diagnosis, maybe 26% to 32%. Now, CT scans can give us an initial look and identify enlarged nodes, but the tricky part is that normal-sized nodes, ones under 1 centimeter, can still harbor microscopic metastases in about 7% to 15% of cases.
So you can't just rely on the size on the CT scan.
Exactly. You can't rely solely on size. This raises the important question. How do we confirm if there's cancer in those nodes? PT-CT scans are very helpful here. They use a radioactive sugar tracer, FDG, to detect metabolically active cancer cells. PT-CT offers increased sensitivity and has a good negative predictive value, maybe 85% to 95% for end stage, meaning if the PT-CT scan of mediastinal nodes is negative, it's very likely there's no nodal involvement. However, if nodes do light up on the PET scan, we call them FDG-ABID, histologic confirmation actually getting a tissue sample is often required before finalizing the treatment plan, especially if it would change the stage from potentially operable to inoperable. This confirmation is usually achieved through invasive staging procedures like endoscopic bronchial ultrasound, EBS, where a scope with an ultrasound probe is used to guide needle biopsies of nodes from within the airways, or mediastinoscopy, a surgical procedure to directly sample nodes, or sometimes via surgery. The key insight here, the shift in practice, is that we often can no longer rely solely on imaging for definitive nodal staging. Direct tissue sampling is frequently required, and this profoundly impacts treatment pathways, deciding between surgery, chemoradiation, or other therapies.
Can you give us a simplified breakdown of the lymph node mapping system? It sounds like there are many different stations or locations that surgeons and oncologists need to track.
Yes, there's a standardized map with 14 specific lymph node stations, essentially precise anatomical locations where lymph nodes cluster within the chest. Stations 10 to 14 are intrapulmonary or hilar nodes, meaning they're within the lung or right at the root, hilum, where the bronchus and vessels enter. Involvement of these nodes on the same side as the tumor defines N1 disease. Stations 2 to 9 are mediastinal nodes, located in the central compartment of the chest between the lungs. Involvement of these ipsilateral, same side, mediastinal nodes means N2 disease. Involvement of contralateral, opposite side mediastinal nodes, contralateral hilar nodes, or the supraclavicular nodes up in the neck, station 1, signifies N3 disease. N3 disease is typically considered unresectable by surgery alone. The 8th edition staging system also adds more nuance by quantifying nodal involvement. For example, it distinguishes between involvement of a single N1 station N1A versus multiple N1 stations N1B. The key takeaway is that prognosis generally worsens as you go from N0, no nodes, to N1, N2, and N3, and also with an increasing number of involved nodal stations. Though interestingly, some specific N1 and N2 subtypes can have similar prognosis depending on the pattern of spread. For instance, the 5-year survival rate for N1A, single N1 station, is around 59%, while for N2A1, single N2 station with no N1 disease, a skip metastasis, it's around 54%, surprisingly close.
And finally, the M stage for distant metastasis, what does that signify for a patient? What are the categories there?
The M stage categorizes distant metastasis, meaning the cancer has spread beyond the primary tumor and the regional lymph nodes. M1A indicates endothoracic metastasis. This means spread within the chest cavity but outside the primary tumor's lobe or regional nodes. Examples include separate tumor nodules in a contralateral opposite lung lobe, or malignant pleural or pericardial nodules on the lining of the lung or heart, or a malignant pleural or pericardial effusion, cancerous fluid buildup. M1b signifies a single extrathoracic metastasis in one distant organ, for example, a single spot in the liver or a bone. M1c means multiple extrathoracic metastases either in one organ or spread to multiple distant organs. What's fascinating and clinically relevant here is that M1a and M1b tumors, despite representing different patterns of metastatic spread within the chest versus the single spot outside, often have similar prognosis, but they require different diagnostic workups and might influence therapeutic approaches. Brain MRI, for instance, is crucial for identifying brain metastases, especially for certain stages or tumor types like adenocarcinoma, as these are common sites of spread. And the impact of stage on survival is stark. The 5-year survival rates drop drastically with increasing stage. From around 90% for the very earliest stage IA1, it plummets down towards 0% for stage IBB, which corresponds to M1C. This just underscores the absolutely vital importance of early detection and accurate staging.
So, once a lung cancer is fully staged using this detailed TNM system, how do doctors decide on the best course of action? Treatment principles must be incredibly individualized now, a truly tailored approach for each person.
Absolutely. Treatment is highly individualized. It's not a cookbook. It necessitates a multidisciplinary team approach involving thoracic surgeons, medical oncologists, radiation oncologists, pulmonologists, pathologists, radiologists, all collaborating to determine the best plan for that specific patient and their specific cancer. For early stage disease, generally, stages SIR and II surgery remains the primary treatment modality with curative intent. The historical standard of care has been an anatomic resection, typically a lobectomy, removing the entire lobe containing the tumor, along with systematic mediastinal lymph node dissection or sampling to accurately stage the nodes. This aims for complete removal of the tumor and any potential local spread. However, as we touched on, recent studies, particularly for smaller peripheral tumors, often less than 2 centimeters in select patients, have shown that lesser resections, like a segmentectomy, removing just the bronchopulmonary segment, or even a wedge resection, removing a small wedge of tissue around the tumor, can offer comparable long-term recurrence and survival rates to lobectomy. This is a really significant advancement because it means some patients, especially those with borderline lung function or multiple health issues, can undergo a less extensive surgery, preserving more healthy lung tissue, which greatly impacts their quality of life after surgery. And for patients who are medically inoperable, meaning they have other health conditions that make surgery too risky, SBRT or stereotactic body radiation therapy has emerged as a highly effective alternative for early stage disease.
SBRT. How does that work?
SBRT delivers very high doses of radiation extremely precisely to the tumor over just a few treatment sessions. It boasts excellent local control rates, often over 85% at 3 years, essentially killing the tumor where it sits. It's a major option for those who can't have surgery.
Okay. And what about the more advanced stages, stage 3 and 4, where surgery isn't typically the first line of defense, or maybe not curative?
Right. For advanced stages, generally, stage IIB and forest surgery is usually not curative and is typically reserved for palliation of specific symptoms if needed at all. Here, systemic therapies become the cornerstone of treatment. For stage IB, which often involves extensive nodal disease but no distant metastasis, chemoradiation combining chemotherapy and radiation therapy is a common standard approach. But here's where things get really exciting and have truly revolutionized care in the last decade or so. The advancements in targeted therapies and immunotherapy.
Targeted therapies and immunotherapy, those are the buzzwords now, right?
They absolutely are, and for good reason. Targeted therapies are designed for tumors that are found to be oncogene addicted. This means the tumor's growth is driven by specific genetic mutations, like mutations in the EGFR gene, or rearrangements in the ALK or RS1 genes, or mutations in BRAF. If testing finds one of these driver mutations, patients can receive drugs that specifically target that altered pathway, often with remarkable effectiveness and fewer side effects than traditional chemotherapy. Immunotherapy, primarily using immune checkpoint inhibitors, works differently. These drugs block pathways like PD-1, PD-L1, or CTLA-4, which cancer cells sometimes use to hide from the body's immune system. By blocking these checkpoints, immunotherapy essentially unleashes the patient's own T cells to recognize and attack the cancer. These therapies, often guided by biomarker testing like PD-L1 expression levels on the tumor, are transforming outcomes for specific patient groups with advanced lung cancer, sometimes providing durable responses even in patients with previously difficult to treat conditions like CNS brain metastases. This shift from relatively non-specific chemotherapy to highly personalized, biomarker-driven medicine based on the tumor's unique genetic and immunologic profile is truly a paradigm shift.
That's incredibly hopeful. And stage 8 ITA sounds like it falls falls into a unique category, kind of a gray area, often requiring a combination of approaches.
Stage 10CA is indeed a spectrum. It represents locally advanced disease, often involving mediastinal lymph nodes and II disease, but without distant metastasis. It can have a wide range of presentations. While many stage 30A tumors are considered too advanced for surgery alone to be curative, if a complete resection is deemed technically possible after careful evaluation, surgery can play a role as part of a multimodality protocol. This often involves neoadjuvant therapy given before surgery or adjuvant therapy given after surgery, typically with chemotherapy, sometimes combined with radiation, chemoradiotherapy. Numerous studies have shown that using systemic therapy in conjunction with surgery for resectable stage 30A disease significantly improves progression-free survival and overall survival by targeting potential micrometastases, tiny deposits of cancer cells that might exist beyond the visible tumor and nodes. A specific, challenging example within stage 3 is the Pancoast tumor or the superior sulcus tumor. These arise at the very apex, the top of the lung.
Pancoast tumors, right? They cause specific symptoms, don't they?
They do. Because of their location, they often invade structures in the thoracic inlet. The ribs, vertebrae, brachial plexus nerves going to the arm, sympathetic nerves. This causes characteristic shoulder and arm pain, muscle wasting in the hand, and sometimes Horner syndrome, a droopy eyelid, constricted pupil, and decreased sweating on one side of the face due to sympathetic nerve involvement. Their treatment is complex and requires a highly coordinated, combined approach, typically starting with chemoradiotherapy to shrink the tumor and treat microscopic spread, followed by a very challenging surgical resection aiming for complete removal, often involving neurosurgeons or orthopedic surgeons as well.
Beyond the lungs, pleura, mediastinum, and more.
Okay, moving beyond the lungs themselves now, let's turn our attention back to the pleura, those thin membranes surrounding the lungs. What happens when fluid builds up in that potential space you mentioned earlier? That sounds like it could cause problems.
It definitely can. That condition is known as a pleural effusion. It basically results from a disruption in the delicate balance of fluid production and absorption in the pleural space. This balance is governed by what are called Starling forces.
Starling forces. Can you break that down?
Think of it like pressure gradients. There's hydrostatic pressure, primarily from capillaries in the parietal pleura, which tends to push fluid out into the space. And then there's oncotic pressure, mainly due to proteins in the blood, which tends to pull fluid back in. There's also lymphatic drainage, which constantly removes the small amount of fluid that's normally produced. Normally, these forces are perfectly balanced, resulting in just a tiny lubricating amount of fluid, maybe 5-15 milliliters total. But even a small imbalance caused by things like increased hydrostatic pressure, like in heart failure, decreased oncotic pressure, like in liver disease, increased capillary permeability, like in inflammation or infection, or blocked lymphatic drainage, like with tumors, can lead to fluid accumulating. As the fluid builds up, it compresses the lung, leading to symptoms like dyspnea or shortness of breath. Understanding these underlying forces is key to figuring out why the effusion is happening and how best to treat it.
And I've heard terms like transudates and exudates used to describe pleural fluid. What's the difference and why does it matter for diagnosis?
Differentiating them is absolutely crucial for narrowing down the diagnosis, as they point towards very different underlying causes. Transudates are generally protein-poor effusions. They result from imbalances in those systemic organs. Starling forces we just talked about think conditions like congestive heart failure, where there's too much fluid pressure overall, or cirrhosis, or kidney failure leading to low protein levels. The pleura itself is usually healthy. Exudates, on the other hand, are protein-rich. They usually indicate a problem with the pleura itself or the adjacent lung, things like inflammation, pneumonia, infection, empyema, malignancy, cancer involving the pleura, or pulmonary embolism. We use a set of criteria called Light's criteria to reliably differentiate them based on the levels of protein and an enzyme called lactate dehydrogenase, LDH, in the pleural fluid compared to the levels in the patient's blood serum. Getting that fluid sample via thoracentesis is often the first diagnostic step.
What about malignant pleural effusions specifically? Effusions caused by cancer. How do those complicate things, and what are the treatment options available?
Malignant pleural effusions, or MPEs, are unfortunately quite common in patients with advanced cancer, particularly lung cancer, breast cancer, and lymphoma. What's fascinating and sometimes frustrating diagnostically is that even after performing 1 or 2 thoracenteses and sending the fluid for cytology, looking for cancer cells, up to 25% of MPEs might still not yield a positive cancer diagnosis from the fluid alone. The cancer cells just aren't shedding into the fluid in detectable numbers. In these cases, more invasive procedures like thoracoscopy, putting a camera into the pleural space to directly visualize the pleura and take biopsies, becomes necessary and is diagnostic in over 90% of cases. Finding an MPE generally signifies advanced metastatic disease, M1A stage as we discussed, and carries a poor prognosis overall. The median survival is often only around 3 to 4 months, though it varies depending on the underlying cancer type and patient factors. However, even though it's usually not curative, local treatment of the MPE can provide significant symptomatic relief, primarily improving shortness of breath and substantially improving the patient's quality of life.
Options range from simple repeated therapeutic thoracentesis, just draining the fluid whenever it reaccumulates, to inserting long-term indwelling pleural catheters, like the Thoracic or SABISTON systems.
Indwelling catheters, how do those work?
These are soft, flexible tubes inserted through the chest wall into the pleural space, with the end tunneling under the skin and exiting the body. They have a one-way valve. Patients or their caregivers can then attach a special vacuum bottle at home to drain the fluid regularly, maybe a few times a week, providing ongoing symptom relief without needing repeated hospital visits or procedures. A really interesting side effect is that these catheters can sometimes induce spontaneous pleurodesis in up to 70% of cases.
Pleurodesis, sticking the layers together.
Exactly. The catheter itself causes enough inflammation that the parietal and visceral pleura fuse together, obliterating the pleural space and preventing further fluid accumulation even after the catheter is eventually removed. Another option to achieve pleurodesis more definitively is talc pleurodesis. Sterile talc powder is instilled into the pleural space, either as a slurry through a chest tube or puffed in during thoracoscopy, talc powderage. Talc is very effective at causing inflammation and getting those layers to stick together, providing durable control of the effusion.
Okay, and what about when the fluid isn't just fluid, but it's actually infected? An empyema, that sounds very serious.
Empyema is indeed a serious infection of the pleural space, essentially. It's a collection of pus between the pleural layers. It typically develops as a complication of pneumonia, but can also occur after surgery or trauma. It tends to progress through distinct stages if not treated promptly. It starts as a simple peripneumotic effusion, thin infected fluid, then progresses to a complicated or fibrinopurulent stage where the fluid becomes thicker, turbid, and starts to loculate, meaning it forms mockets or compartments separated by fibrin strands. If it progresses further, it enters an organizing or chronic phase where that mucopurulent debris and fibrin form a thick, inelastic pleural rind or peel that encases the lung, trapping it and preventing it from expanding properly. Treatment absolutely requires complete drainage of the infected fluid, typically with image-guided insertion of chest tubes or small-bore catheters, along with appropriate long-term antibiotics targeting the causative bacteria. For loculated effusion, sometimes multiple catheters are needed, or intrapleural fibrinolytic agents, medications like TPA and DNase that are instilled into the chest tube to help dissolve the fibrin loculations and liquefy the thick pus, facilitating drainage might be used. If these conservative measures fail, or if the patient presents in the chronic organizing stage with a trapped lung, surgical intervention like VATS decortication, minimally invasive removal of the pleural rind, or even an open thoracotomy and decortication may be necessary to fully drain the pus and allow the lung to re-expand.
There's also a condition called chylothorax, which sounds like a very specific type of fluid with a unique origin involving the lymphatic system.
That's right. Chylothorax is a relatively rare but often nutritionally devastating condition where chyle leaks into the pleural space. Chyle is lymphatic fluid originating from the intestines after fat digestion. It's typically milky white in appearance and very rich in triglycerides, fats, and lymphocytes, immune cells. It travels up through the body via the thoracic duct, the main lymphatic channel, which runs through the mediastinum before emptying into the bloodstream near the neck. Chylothorax occurs when this thoracic duct is disrupted, usually due to trauma, like surgery, especially esophageal or cardiac surgery or penetrating injury, or sometimes due to obstruction by neoplasms, tumors, often lymphomas. Because chyle is so rich in fat, protein, and immune cells, a persistent leak leads to significant malnutrition, dehydration, and immunodeficiency. Initial management is usually conservative, aiming to reduce chyle flow. This involves making the patient NPO, nothing by mouth, and starting total parenteral nutrition, intravenous feeding, or sometimes using a very low-fat diet supplemented with medium-chain triglycerides, which are absorbed differently bypassing the thoracic duct. Medications like octreotide can also help reduce chyle production. If conservative measures fail after a week or two, more invasive treatment is needed. Options include surgical ligation,
tying off of the thoracic duct, usually via VATS or interventional radiology techniques like percutaneous embolization of the leaking duct.
So fluid buildup is clearly a problem, but air in the wrong place can be just as problematic, if not sometimes more acutely dangerous, leading to a collapsed lung.
Indeed. Pneumothorax is the accumulation of air in that potential pleural space, which breaks the seal between the lung and the chest wall, causing the lung to collapse due to its natural elastic recoil. Spontaneous pneumothorax is the most common type in otherwise healthy people. Primary spontaneous pneumothorax often affects tall, thin young men and is frequently caused by the rupture of small subpleural blebs or bullies. These are like tiny, thin-walled blisters on the lung surface, usually at the apex. Secondary spontaneous pneumothorax occurs in people with underlying lung disease like COPD or cystic fibrosis. The truly life-threatening variant, though, is tension pneumothorax.
Tension pneumothorax, that sounds urgent.
It is a true medical emergency. Here, air enters the pleural space during inspiration, often through a flap-like tear in the lung or chest wall, but it cannot escape during expiration. It acts like a one-way valve. Air progressively accumulates, building up positive pressure within the affected hemothorax. This causes the lung to completely collapse, but more critically, it pushes the entire mediastinum, the heart, trachea, great vessels, over into the contralateral opposite chest. This shift severely compresses the healthy lung and kinks the great veins, returning blood to the heart, leading to rapid cardiovascular collapse and potentially death if not treated immediately. The immediate treatment is needle decompression, inserting a large bore needle into the chest to let the trapped air escape, followed by definitive chest tube insertion. The key insight is that simple air, if trapped under pressure in the wrong place, can become rapidly fatal.
Okay, that's terrifying. So how is it regular pneumothorax, one that isn't under tension, generally treated? Does it always require a chest tube or surgery?
Not always. Small pneumothoraces, say less than 2 to 3 centimeters, especially if they occur iatrogenically after a procedure like a lung biopsy needle aspiration, and the patient has minimal symptoms, may resolve spontaneously over days to weeks as the air is gradually reabsorbed. Observation might be appropriate. However, larger pneumothoraces, or those causing significant symptoms like shortness of breath or chest pain, require drainage to allow the lung to re-expand. This is typically done with a small bore catheter, pigtail catheter, or a standard chest tube connected to suction or a water seal device. If there's a persistent air leak, meaning air continues to bubble through the chest tube system for more than, say, 5 days, or if the lung fails to fully re-expand despite drainage, further intervention is usually needed. Surgical intervention, usually via minimally invasive V8s, is generally recommended for patients with persistent air leaks, recurrent spontaneous pneumothoraces, a second episode, or if a pneumothorax occurs in the contralateral lung, bilateral pneumothoraces. It's also considered for certain high-risk professions, like pilots or scuba divers, after even a first episode.
During surgery, the surgeon typically looks for and resects any visible apical blebs or bullae, stapling off the abnormal lung tissue, and then performs a procedure to encourage pleurodesis to make the lungs stick to the chest wall and prevent future collapses. This is often done by mechanical abrasion of the choroidal pleura, gently rubbing it to cause inflammation, or sometimes chemical pleurodesis with talc. And a crucial nugget for listeners: after a spontaneous pneumothorax, especially if they haven't had surgery with pleurodesis, avoiding activities involving significant pressure changes, like scuba diving or flying in unpressurized aircraft, is really important due to the increased risk of recurrence, which could be disastrous in those environments.
Okay, now shifting focus again, right in the very center of the chest lies the mediastinum. You described it as a busy corridor for many vital structures, often kind of hidden in plain sight between the lungs. What are the potential dangers lurking there, and how might they manifest?
The mediastinum is that central compartment. It's anatomically defined as the space bordered by the thoracic inlet up top, the diaphragm below, the sternum in front, the vertebral column behind, and laterally by the parietal pleura covering the lungs. It's a critical hub, housing the heart and its great vessels: aorta, vena cava, pulmonary artery, the trachea and main bronchi, the esophagus, the thymus gland, major nerves, vagus, phrenic, sympathetic chain, and numerous lymph nodes and lymphatic channels like the thoracic duct. Masses arising within or compressing these structures can be entirely asymptomatic, often found incidentally on a chest X-ray done for other reasons. Or they can cause quite severe symptoms due to compression or invasion of these vital neighbors. For example, compression of the superior vena cava, the large vein draining the upper body, can lead to superior vena cava SVC syndrome, causing dramatic swelling of the head, neck, face, and upper extremities, along with prominent neck veins. Compression or invasion of the trachea or bronchi can cause cough, shortness of breath, or wheezing. Involvement of the esophagus can lead to dysphagia, difficulty swallowing.
And irritation or involvement of nerves can cause things like hoarseness from recurrent laryngeal nerve involvement or diaphragm paralysis from phrenic nerve involvement.
It's traditionally divided into different compartments, right, like anatomical neighborhoods. Do specific types of masses tend to favor certain areas? Does knowing the location help narrow down what it might be?
Yes, absolutely. Dividing the mediastinum into compartments is incredibly helpful for developing a differential diagnosis, as certain types of tumors and cysts have a strong predilection for specific locations. Traditionally, it's divided into three main compartments based on a lateral chest X-ray view, although CT provides much better detail now. The anterosuperior compartment, in front of the heart and great vessels, is the most common site for mediastinal masses overall, accounting for about half of them. In adults over 40, thymomas, tumors of the thymus gland, are the most frequent neoplasm here, followed by retrosternal substernal goiter, which is an enlarged thyroid gland extending down from the neck. In younger adults and children, lymphomas and germ cell tumors, like teratomas, are more common in this location. The middle mediastinum contains the heart, pericardium, great vessels, trachea, main bronchi, esophagus, and lymph nodes. Here you'd typically find lymphomas, tumors arising from the heart or vessels themselves, and various benign cysts like pericardial cysts, fluid sacs near the heart, and bronchogenic cysts arising from the airways. Finally, the posterior compartment, also called the paravertebral sulci, the gutters alongside the spine, primarily houses neurogenic tumors, tumors arising from nerves or nerve sheath cells. These are actually the most common primary mediastinal tumors overall, though many mediastinal masses are secondary, like lymphomas or metastases. About 25% of primary neurogenic tumors are malignant. Common benign types include schwannomas and neurofibromas arising from nerve sheaths.
You mentioned dumbbell tumors earlier in the context of neurogenic tumors. It sounds like a particularly tricky situation extending into the spinal column. How are those managed?
They are tricky. What's fascinating and surgically challenging is that about 10% of these posterior mediastinal neurogenic tumors, particularly schwannomas, can have extensions through the intervertebral foramen, the hole where the spinal nerve exits into the spinal canal itself. This creates a characteristic dumbbell shape on imaging. A larger component in the paravertebral space, a narrow waist as it passes through the foramen, and an intraspinal component, potentially compressing the spinal cord or nerve roots. Resecting these requires careful planning and often a complex, multidisciplinary approach, frequently involving both a thoracic surgeon and a neurosurgeon. It's often done in 2 stages or sometimes concurrently. Typically, the neurosurgeon might perform a posterior laminectomy, removing part of the vertebral bone, to address and decompress the intraspinal component first, minimizing the risk of neurological injury during manipulation of the tumor. Then the thoracic surgeon addresses the intrathoracic portion, often through a thoracotomy or VATS approach. It really highlights the need for coordinated surgical expertise when tumors cross anatomical boundaries.
And what about those primary mediastinal cysts you mentioned? Are they usually problematic or mostly just benign discoveries found incidentally?
Primary mediastinal cysts account for a significant portion, maybe 20%, of all mediastinal masses, and the good news is they are usually benign. Bronchogenic cysts are the most common type. They are congenital anomalies originating from abnormal budding of the primitive tracheobronchial tree during development. They are typically found near the trachea or main bronchi, often just posterior to the carina where the trachea splits. While often asymptomatic in adults and found incidentally in infants and young children, they can enlarge and compress the trachea or esophagus, causing significant respiratory compromise or feeding difficulties, and often require resection. Pericardial cysts are the second most common, usually located in the cardiophrenic angle where the heart meets the diaphragm, most often on the right side. They are thin-walled and typically contain clear, spring water-like fluid. They are almost always benign and often don't require treatment unless very large or causing symptoms. Enteric cysts, or duplication cysts, arise from the primitive foregut, the embryonic structure that forms the digestive tract, and are usually found in the posterior mediastinum, often attached to the esophagus.
Even though most cysts are benign, they often warrant removal if they're causing symptoms, if there's diagnostic uncertainty. It's hard to be 100% sure it's just a cyst without removing it, or sometimes just due to their potential to grow or become infected later on.
Now, let's dive into some of the specific primary mediastinal neoplasms, the actual tumors. Thymomas, you said, are common in the front, and they're frequently associated with some surprising systemic syndromes, aren't they? Almost like they're communicating with the body's entire system.
They are. It's quite remarkable. Thymomas are the most common primary neoplasm of the anterosuperior mediastinum. They arise from the epithelial cells of the thymus gland. They are considered malignant tumors, but they have a wide spectrum of behavior ranging from very indolent
slow-growing, unlikely to spread, classified as type A, to more aggressive forms, type B1, B2, B3, and thymic carcinoma that can invade locally or even metastasize. What's truly fascinating and clinically very important is their strong association with various paraneoplastic syndromes, particularly autoimmune disorders. Most famous association is with myasthenia gravis, MG.
Myasthenia gravis, the muscle weakness disorder.
Exactly. It's an autoimmune disease where antibodies attack the neuromuscular junction, causing fluctuating muscle weakness. Up to 50% of patients with thymoma also have myasthenia gravis. And conversely, about 10–15% of patients diagnosed with myasthenia gravis are found to have an underlying thymoma. Other significant paraneoplastic associations include pure red blood cell aplasia, where the bone marrow stops producing red blood cells, leading to severe anemia, and hypogammaglobulinemia, low levels of antibodies, leading to a weakened immune system and recurrent infections, sometimes called Good syndrome. Thymomas are now staged using the AJCC-TNM system, 8th edition, which helps predict prognosis and guide treatment based on the extent of invasion. The primary treatment for almost all thymomas, even non-invasive ones, is complete surgical resection of the tumor and the entire thymus gland, thymectomy. This is often curative for early-stage disease and can also lead to improvement or even remission of associated myasthenia gravis in many patients. For more invasive forms, multidisciplinary care involving chemotherapy and/or radiation therapy is often needed in addition to surgery. It's a prime example of how a tumor localized to one area can have profound, widespread effects on the body's systems.
That link to myasthenia gravis is really striking. Now, what about germ cell tumors? You mentioned they can contain some truly unexpected components, making them quite unique finds in the chest.
Indeed. Mediastinal germ cell tumors, and GCTs, arise from primordial germ cells that essentially got lost during embryonic development. Instead of migrating to the gonads, testes, or ovaries, they settled in the midline of the body, most commonly in the anterosuperior mediastinum. This is the most common extracognathal site for GCTs. The most common type of mediastinal GCT is the teratoma. What's truly surprising, and often fascinating for pathologists, is that benign mature teratomas can contain elements derived from all three primitive embryonic germ layers, ectoderm, mesoderm, endoderm. This means when you cut into one, you might find well-differentiated mature tissues like skin, hair follicles, sebaceous glands, cartilage, bone, teeth, respiratory or intestinal lining, or even pancreatic or thyroid tissue. It's like a collection of misplaced body parts. These benign teratomas usually require a complete surgical excision, which is curative. Then you have the malignant non-recombinous germ cell tumors. These are divided into seminomas and non-seminomas, which include embryonal carcinoma, yolk sac tumor, choriocarcinoma, and mixed types. These are often aggressive tumors, typically occurring in young men. They are often diagnosed with the help of tumor markers in the blood, like alpha-fetoprotein, AFP, and beta-human chorionic gonadotropin, BuddyHCG. Unlike teratomas, these malignant GCTs are primarily treated with platinum-based chemotherapy, sometimes followed by radiation. Surgery might be used afterward for salvage or to remove any residual disease that remains after chemotherapy.
There are also lymphomas and endocrine tumors that can manifest in the mediastinum, adding yet more complexity to this central region.
Yes, lymphomas, which are cancers arising from the lymphatic system, frequently involve the mediastinal lymph nodes, but they are relatively rarely confined solely to the mediastinum, without evidence of disease elsewhere. Both Hodgkin lymphoma and various types of non-Hodgkin lymphoma can present with mediastinal masses, often causing symptoms like chest pain, cough, shortness of breath, or SVC syndrome. Diagnosis usually requires obtaining a substantial tissue sample, often more than just a fine needle aspiration, maybe via core needle biopsy or surgical biopsy, for accurate subtyping, which is critical for choosing the right chemotherapy regimen. As for endocrine tumors, intrathoracic mediastinal thyroid tumors are uncommon, making up maybe 1% of mediastinal masses. Most often, these represent benign goiters extending down from the neck, substernal goiter, but rarely can be primary thyroid cancers. Parathyroid adenomas, the benign tumors that cause primary hyperparathyroidism, leading to high calcium levels, can sometimes be located ectopically in the mediastinum in about 10% of cases, often near or within the thymus gland. Finding these requires specialized imaging and sometimes meticulous surgical exploration.
And finally, mediastinal neuroendocrine tumors, often originating from thymic tissue, thymic carcinoids, can sometimes be hormonally active. For example, they might produce ACTH, leading to Cushing's syndrome with symptoms like weight gain, high blood pressure, and diabetes.
The body's framework chest wall and its issues.
Okay, let's shift our focus outward now to the body's framework itself, the chest wall. Sometimes this structure develops with noticeable variations, deformities that can be quite visible.
Yes, these are known as congenital chest wall deformities. While often primarily a cosmetic concern, they can certainly impact a person's body image, and occasionally, if severe, they can affect cardiopulmonary physiology. The most common by far is pectus excavatum, often referred to as funnel chest. It occurs in maybe 1 in 400 children, and it's much more common in males, about a 4-to-1 ratio. It's characterized by a sunken or depressed appearance of the sternum and adjacent costal cartilages, thought to be due to uneven overgrowth of those cartilages pushing the sternum inward. It can be symmetric, right in the middle, or asymmetric, maybe deeper on one side. Severity is often assessed clinically, but can be quantified using caliper measurements of the depth, or, more objectively, with the Haller index calculated from a CT scan. The Haller index compares the transverse diameter of the chest to the shortest distance between the sternum and the spine. A value over 3 or 3.25 generally indicates a significant depression that might potentially compress the heart or lungs.
So how are these types of deformities addressed? Is it always surgical, or are there other options, and when is the best time to intervene?
Well, for pectus excavatum, surgical repair is typically indicated for patients with documented physiological impairment, though this is less common, significant progression during growth, persistent pain, or substantial negative body image issues that affect their quality of life. There are 2 main surgical techniques widely used. The older, more traditional approach is the Ravitch technique, first described back in 1949. This involves making an incision over the sternum, resecting the deformed costal cartilages, often performing a transverse osteotomy, a cut, across the sternum to allow it to be lifted forward, and then stabilizing it, sometimes with sutures or a small strut. The other, now more commonly performed approach is the minimally invasive Ness technique, introduced by Dr. Donald Ness in 1987. This involves making small incisions on the sides of the chest. A curved stainless steel bar, or sometimes multiple bars, is then passed underneath the sternum, guided by thoracoscopy, a camera inside the chest, and flipped into position to push the sternum forward, correcting the depression from within. No cartilage is resected. This bar is typically left in place for about 2 to 3 years, and then removed in a second, smaller procedure. The optimal timing for surgery for either technique is generally considered to be during the mid-teenage years, typically between 13 and 16. This allows for most of the chest wall growth to have occurred, but still takes advantage of the relative flexibility of the chest before it becomes too rigid, and it allows the patient to be actively involved in the decision-making process.
Okay. And what about the opposite condition, pectus carinatum, often called pigeon chest? How is that managed?
Pectus carinatum, or pigeon chest, is the second most common congenital chest wall deformity. It's characterized by an outward protrusion or displacement of the sternum and/or adjacent ribs. The classic form is a keel chest, a distinct ridge-like protrusion, usually of the lower sternum. Interestingly, for pectus carinatum, especially in patients who are still growing and have relatively flexible chest walls, non-surgical treatment with corrective bracing is often the first line and can be very successful. Custom-fitted braces apply gentle, constant pressure to gradually reshape the protruding chest over time, often worn for many hours a day for several months or years. Success rates exceeding 80% have been reported with good compliance. If bracing fails, isn't tolerated, or for patients with more rigid deformities or who have finished growing, surgical repair is an option. This usually involves a procedure similar in principle to the Ravitch technique for excavatum, involving resection of the overgrown deformed cartilages and potentially a sternal osteotomy to reposition the sternum. And while we're talking about congenital deformities, another fascinating, though much rarer condition is Poland syndrome. This is a unique, usually unilateral syndrome characterized by the congenital absence of the pectoralis major muscle, and often the minor, on one side, frequently accompanied by underdevelopment or absence aplasia of ribs on the same side, typically the 2nd through 5th, and often associated with hypoplasia, underdevelopment, of the breast and nipple on that side, as well as anomalies of the hand on the same side, like fused or short fingers. It's a very striking constellation of birth defects affecting the chest wall and upper limb.
Wow, Poland syndrome sounds quite complex. Now, beyond these developmental issues, tumors can also specifically affect the chest wall itself. You mentioned they're quite rare overall, but what are the key considerations when they do occur?
Primary chest wall tumors, those originating from the bones, ribs, sternum, clavicle, scapula, or soft tissues, muscles, cartilage, connective tissue, nerves of the chest wall, are indeed rare. They account for only about 0.04% of all new cancer diagnoses. But what's important to remember is that a high proportion of these primary tumors, roughly 60%, are malignant. Metastatic tumors spreading to the chest wall from cancers elsewhere, like lung, breast, kidney, are actually more common than primary malignant tumors. Clinically, they typically present as a palpable, often enlarging mass on the chest wall. Soft tissue masses, like sarcomas, are often painless initially, which can delay diagnosis. Bony lesions, however, are usually painful early on due to irritation or destruction of the periosteum, the sensitive outer covering of the bone.
What's involved in diagnosing and treating these rare but often serious tumors? I imagine removing them requires quite a bit of specialized planning and reconstruction.
Diagnosis requires a thorough workup, starting with comprehensive imaging. CT scans are excellent for evaluating bone involvement and destruction. MRI is often better for assessing the extent of soft tissue involvement and relationship to nerves and vessels. PT-CT can help determine if the tumor is metabolically active, suggesting malignancy, and look for distant spread. However, imaging alone isn't enough. A biopsy is mandatory to obtain a definitive tissue diagnosis and determine if the tumor is benign or malignant. And if malignant, the specific type and grade, which is crucial for guiding treatment. This might be a core needle biopsy or sometimes an open incisional or excisional biopsy. The cornerstone of treatment for almost all malignant primary chest wall tumors, and even some aggressive benign ones, is complete surgical resection with wide negative margins, meaning removing the tumor along with a surrounding cuff of healthy tissue to ensure no cancer cells are left behind. Because these tumors often involve the ribs or sternum, this frequently requires en bloc resection, removing the involved ribs, potentially part of the sternum, and any adjacent structures that might be invaded, such as the underlying pleura, a portion of the lung, or even the diaphragm. This, of course, creates a significant defect in the chest wall. So reconstruction is a critical part of the operation. The goals are to restore chest wall stability to prevent paradoxical movement or flail chest, protect the underlying organs, maintain respiratory mechanics, prevent lung herniation, and achieve an acceptable cosmetic result. Reconstruction often involves using synthetic materials like rigid meshes, Pro-Legi Marlex, Prolene, or non-rigid patches, for example, Gore-Tex, sometimes combined with bone cement to bridge the defect. This framework is then typically covered with well-vascularized soft tissue, usually using muscle flaps mobilized from nearby areas like the latissimus dorsi, pectoralis major, or rectus abdominis muscles. The planning for both the resection and reconstruction is meticulous and often requires collaboration between thoracic surgeons and plastic surgeons.
What are some of the more common types of these primary and malignant chest wall tumors that surgeons might encounter?
Among malignant bone tumors of the chest wall, chondrosarcoma, a cancer of cartilage, is the most common. It accounts for about 20% of all primary bone tumors found in the chest wall. Wide surgical resection is the primary treatment, as they tend to be resistant to radiation and chemotherapy. With complete resection, the 5-year survival rate is reasonably good, around 70%. Other malignant bone tumors like osteosarcoma or Ewing sarcoma can also occur but are less common here. Among malignant soft tissue tumors, various types of sarcomas are actually the most common group overall for primary malignant chest wall tumors. These can arise from muscle, rhabdomyosarcoma, leiomyosarcoma, fat, liposarcoma, fibrous tissue, fibrosarcoma, malignant fibrous histiocytoma, or nerves, malignant peripheral nerve sheath tumor. Again, wide surgical resection is the mainstay of treatment, often combined with radiation therapy and sometimes chemotherapy, depending on the specific type and grade.
Okay. And finally, moving beyond developmental issues and tumors, just everyday trauma and infections can also affect this vital area, often with immediate and dramatic consequences.
Absolutely. Thoracic trauma is quite common, accounting for maybe 10-15% of all trauma cases presenting to emergency departments. Rib fractures are perhaps the most frequent specific injury after blunt chest wall trauma. While often very painful, the main concern with rib fractures isn't just the broken bone itself, but the potential for associated underlying injuries to the lung, like pneumothorax or hemothorax blood in the pleural space, or lung contusion bruising of the lung tissue, or even abdominal organs if lower ribs are involved. Pain control is key to allow adequate breathing and prevent complications like pneumonia. A more severe pattern of injury is flail chest. This occurs when multiple adjacent ribs are fractured in 2 or more places, creating an unstable segment of the chest wall that is no longer continuous with the rest of the rib cage. This unstable segment moves paradoxically with breathing. It gets sucked inward during inspiration when the rest of the chest expands, and bulges outward during expiration when the rest of the chest contracts. This paradoxical movement significantly impairs the efficiency of breathing and increases the work of breathing. It's often associated with significant underlying lung contusion as well. Management requires meticulous pain relief, often epidural anesthesia or nerve blocks, aggressive pulmonary toilet to keep airways clear, and sometimes positive pressure ventilation or even surgical stabilization, rib plating, in severe cases. Sternal fractures, though less common than rib fractures, can occur from direct blunt trauma, classically from a steering wheel impact in a car crash before seatbelts and airbags were universal. While the fracture itself might heal, the main concern is the potential for significant underlying injury to the heart, cardiac contusion, valve injury, or even aortic disruption or lungs, so careful evaluation for these associated injuries is crucial. Chest wall infections are relatively uncommon in healthy individuals, but can arise from penetrating trauma spread from adjacent infections like emphysema, post-operative complications, especially sternal wound infections after cardiac surgery, hematogenous seeding spread through the bloodstream, or sometimes in the setting of radiation injury or immunosuppression. Treatment usually involves antibiotics and often surgical debridement, removal of infected tissue, and potentially complex reconstruction if there's significant tissue loss. Sternal osteomyelitis, an infection of the sternum bone, particularly after median sternotomy for heart surgery, can be a very challenging problem requiring aggressive surgical management.
Precision and planning the art of thoracic operations.
Okay, we've covered a lot about what can go wrong. Now let's talk about fixing things. Performing surgery in such a vital and complex area like the thorax demands meticulous planning and careful patient assessment. What are the key physiological evaluations done before a major thoracic operation like a lung resection to ensure a patient can actually tolerate it?
Patient selection and preoperative risk assessment are absolutely fundamental to achieving good outcomes in thoracic surgery. You really need to know if the patient has enough reserve to withstand losing some lung function. Cardiopulmonary function, the combined health of the heart and lungs, is paramount. For planned lung resections, pulmonary function tests, PFTs, specifically spirometry, are essential. The key metric we look at is the FEV1, the forced expiratory volume in 1 second, which reflects airflow. While most patients with a preoperative FEV1 greater than about 60% of predicted can usually tolerate a lobectomy without major issues, if the SEV1 is lower than that, further testing is needed to calculate the predicted post-operative FEV1, PAPO-FEV1. This estimates how much lung function the patient will likely have left after the planned amount of lung is removed, for example, after removing 1 lobe out of 5. Historically, patients with a PAPO-FEV1 below 40% were considered high risk, and below 30% very high risk for major complications like respiratory failure, prolonged ventilation, or even death. However, decisions are highly individualized now, considering other factors too.
Another important PFT measurement is the diffusing capacity for carbon monoxide, DELCO. This measures how well gas, in this case a tracer gas, carbon monoxide, moves from the alveoli into the bloodstream. It reflects the efficiency of the gas exchange surface area. A low preoperative DELCO, or predicted postoperative DELCO, below 40-50% is also associated with increased perioperative risk.
So FEV1 and JILCO are key numbers. But what about for those patients who seem more disabled than their spirometry might suggest, or who are borderline based on those numbers? Is there a way to get a more comprehensive real-world picture of their overall fitness?
Yes, exactly. For those marginal candidates, or when there's a discrepancy between their reported symptoms, like shortness of breath, and their resting PFT results, cardiopulmonary exercise testing, CP8, is extremely valuable. CP involves having the patient exercise, usually on a stationary bicycle or treadmill, while continuously monitoring their heart rate, electrocardiogram, ECG, blood pressure, ventilation, oxygen uptake, and carbon dioxide output. It provides a dynamic, integrated assessment of the entire cardiopulmonary axis under stress. The key metric derived from CP is the maximal oxygen consumption, VO2 max, which represents the patient's peak aerobic capacity. A VO2 max less than about 15 millikiegemin is generally associated with increased risk for complications after lung resection, and a VO2 max below 10 millikiegemin indicates very high risk. CP can also sometimes uncover clinically silent cardiac disease, like ischemia, that might not show up on standard resting tests. It gives a much better global picture of their functional reserve. And of course, a non-test, but perhaps the most critical intervention for smokers undergoing thoracic surgery.
They absolutely must stop smoking immediately, ideally at least 4 to 8 weeks before the planned surgery. Smoking cessation significantly reduces the risk of post-operative pulmonary complications like pneumonia, atelectasis, and bronchospasm, as well as wound healing problems. It's non-negotiable. We also sometimes assess diaphragm function, perhaps using a fluoroscopic sniff test or chest ultrasonography to look for paradoxical movement, where the diaphragm moves up instead of down during inspiration. Diaphragm paralysis or paresis can significantly impact breathing mechanics and might explain unexpected breathlessness or influence surgical planning.
Okay, so patient selection is key. Now, the surgical approach itself, how the surgeon actually gets into the chest, must depend entirely on the problem and its location. What are the main ways surgeons enter this complex space, and how has technology changed the options?
The field has really undergone a major shift towards minimally invasive techniques over the past couple of decades, driven by the clear benefits for patients. Video-assisted thoracoscopic surgery, VATS, And more recently, robotic-assisted thoracoscopic surgery, ARSTs, are now the preferred approaches for a wide range of thoracic problems, including diagnosis of lung nodules, biopsy of mediastinal masses, treatment of pleural effusions and empyema, sympathectomy, and even major anatomical lung resections like lobectomy and segmentectomy for early-stage lung cancer in many centers. The key advantage of these minimally invasive approaches is that they use small incisions, typically 1 to 4 ports of about 512 millimeter, through which a camera, thoracoscope, and specialized long instruments are inserted. Crucially, the ribs are not spread apart with a mechanical retractor like in traditional open surgery. This avoidance of rib spreading leads to significantly less postoperative pain, reduced surgical trauma and inflammation, shorter hospital stays, faster recovery and return to normal activities, and often improved cosmetic outcomes compared to open thoracotomy. It really has been a game changer for patient recovery.
That sounds much better for the patient. But there must still be situations where an open approach, like a larger incision with rib spreading, is necessary or preferred.
Absolutely. While minimally invasive techniques are used widely, there are definitely still indications for traditional open procedures. For operations requiring wider access to one side of the chest, a thoracotomy is the standard open approach. The patient is typically positioned lying on their side, lateral decubitus position. An incision is made between the ribs, often curving around the tip of the scapula. Posterolateral thoracotomy being the classic workhorse incision, though muscle-sparing variations are common now. The ribs are then gently spread apart using a retractor to provide direct visualization and access for the surgeon's hands and instruments. The specific location of the thoracotomy, e.g. anterior, axillary, posterior, depends on the target structure within the chest. For operations requiring broad access to the mediastinum, the heart, the great vessel, or potentially both pleural spaces simultaneously, a median sternotomy is the common approach. This involves making a vertical incision down the midline of the chest directly over the sternum. The sternum bone is then divided longitudinally using a specialized saw. This provides excellent wide exposure to the entire central chest, and is the standard incision for most cardiac surgeries, as well as for some large anterior mediastinal tumors or bilateral lung procedures. The sternum is wired back together at the end of the procedure. For even more extensive bilateral exposure, needed for procedures like bilateral lung transplantation, resection of very large mediastinal tumors that extend into both sides, or complex tracheal reconstructions, the clamshell incision, technically a bilateral anterior thoracotomy with transverse sternotomy, can be used. This involves making incisions under both breasts, connecting them across the midline by dividing the sternum transversely, horizontally. It essentially opens the entire front of the chest like a clamshell, providing maximal exposure, although it is associated with more postoperative pain and potential healing complications than other approaches.
Okay. Finally, let's touch upon tracheal surgery. The trachea, our windpipe, is obviously central to breathing, but also sounds incredibly delicate. What are the unique challenges of operating on this structure?
The trachea is indeed a delicate and absolutely vital structure. Operating on it presents unique challenges. In adults, it's about 10 to 13 centimeters long, extending from the larynx down to the carina where it splits into the main bronchi. It's supported by about 18 to 22 incomplete, C-shaped cartilaginous rings, which keep it from collapsing, connected by a soft membranous wall posteriorly. Its internal diameter is critical for airflow. Even relatively small reductions in diameter can have a huge impact on breathing due to the physics of airflow resistance. A 50% reduction in the cross-sectional area increases airflow resistance 16-fold during laminar flow, and astonishingly up to 32-fold during turbulent flow, like when breathing rapidly or coughing. This just highlights how quickly even seemingly small narrowing, or stenosis, can severely compromise breathing and become symptomatic. There's very little room for error.
Wow, that resistance increases exponentially. So what causes these critical narrowings or stenoses? Is it always tumors, or are there other common causes?
Not always tumors, no. In fact, benign stenosis, meaning non-cancerous narrowing, is more common than primary tracheal cancer. The most frequent cause of acquired benign tracheal stenosis, historically and still today, is iatrogenic injury related to tracheotomy tubes or prolonged endotracheal intubation from mechanical ventilation. Particularly the older high-pressure, low-volume cuffs on endotracheal tubes could exert excessive pressure on the tracheal wall, leading to ischemia, lack of blood flow, cartilage damage, inflammation, and subsequent scarring and narrowing after the tube is removed. Modern low-pressure, high-volume cuffs have reduced this risk, but it still occurs, especially with prolonged intubation or traumatic intubations. Symptoms like shortness of breath, dyspnea, wheezing, or stridor, that high-pitched breathing sound, usually don't appear until the tracheal lumen is narrowed by more than 50%. The standard treatment for symptomatic significant benign stenosis is surgical resection of the narrowed segment with primary end-to-end anastomosis, essentially cutting out the bad part and carefully sewing the healthy ends of the trachea back together. This provides the best long-term results when feasible. Other options like endoscopic dilation or stenting are usually temporary measures or for patients unfit for major surgery.
Okay. What about actual tumors of the trachea? Are they common, and how are they typically approached surgically?
Primary tracheal tumors are thankfully quite rare, but unfortunately the majority of them, maybe 80–90%, are malignant. The two most common types of primary malignant tracheal tumors are squamous cell carcinoma, often associated with smoking, and adenoid cystic carcinoma, a slower growing but relentless tumor known for perineural invasion. More commonly, the trachea can be involved by direct invasion from adjacent cancers like thyroid, esophageal, or lung cancer. Similar to benign stenosis, these tumors are often asymptomatic until they obstruct more than 50% of the lumen, which often means they are quite advanced by the time they're diagnosed. Complete surgical resection with reconstruction is the treatment of choice whenever possible, offering the only real chance for cure. However, there's a significant technical limitation. The maximum length of trachea that can typically be safely resected and reconstructed with a primary anastomosis is only about 4 to 5 centimeters, roughly half the total length of the adult trachea. Trying to bridge a longer gap puts too much tension on the suture line, risking breakdown dehiscence. Various mobilization techniques like freeing up the larynx from the hyoid bone in the neck, a suprahyoid release, can provide maybe an extra centimeter or so of length, allowing for slightly longer resections in some cases. But extensive resections remain very challenging. Radiation therapy is often used for unresectable tumors, or after resection for certain types like adenoid cystic carcinoma.
And tracheal trauma must present its own set of urgent, potentially catastrophic challenges.
Absolutely. Tracheal trauma, resulting from either blunt force to the neck, like hitting a steering wheel or a clothesline injury, or penetrating injuries, like stab or gunshot wounds, is often severe and frequently associated with other life-threatening injuries to major blood vessels, the esophagus, or the spinal cord. Injuries can range from lacerations or tears in the tracheal wall to complete transection or shattering of the cartilage. Early airway protection, securing the airway, often with intubation distal to the injury if possible, or sometimes emergency tracheotomy, and prompt primary surgical repair are crucial to reestablish airway continuity, prevent aspiration, and avoid devastating long-term complications like stenosis or tracheoesophageal fistula. Speaking of which, tracheoesophageal fistula, TEF, an abnormal connection between the trachea and esophagus, is another rare but serious complication, most often occurring after prolonged intubation with cuff erosion in critically ill patients, or sometimes due to malignancy or trauma. It allows food, liquids, and secretions to pass into the airway, leading to recurrent pneumonia and respiratory failure. Equally severe, though even rarer, are tracheoinnominate fistulas, a catastrophic connection between the trachea and the innominate artery, a major vessel branching off the aorta. This usually presents with massive, often fatal hemorrhage. Both the EFTF and tracheoinnominate fistula require urgent surgical intervention, often involving repair of both structures and interposition of healthy tissue, like a muscle flap between them, to prevent recurrence. These are among the most challenging emergencies in thoracic surgery.
As we wrap up this truly deep dive, it's crystal clear that the thorax is an absolute marvel of biological engineering. It's not just a box of bones. It's this incredibly complex symphony of structures working together, often under immense pressure. It's hard to imagine something so intricate simply functioning second by second.
Absolutely. It really is astounding when you stop to think about it. From the intricate fractal branching network of the lungs and their mind-boggling surface area for gas exchange, to the dynamic, protective, yet flexible cage of the chest wall, and all the vital, bustling structures packed into the mediastinum, this entire region demonstrates incredible resilience and adaptability. And the advancements we've seen in just the last couple of decades in diagnosis and treatment are truly remarkable. Particularly the impact of lung cancer screening trials and shifting diagnoses to earlier, more curable stages, and the revolution brought about by personalized therapies, the targeted agents and immunotherapies. They're genuinely transforming patient outcomes and offering real hope in ways we couldn't have realistically imagined not that long ago. It's a field that's constantly learning, evolving, and pushing the boundaries of what's possible.
We've certainly covered a huge amount of ground today, from the foundational anatomy and physiology through a whole range of complex pathologies, congenital, infectious, traumatic, neoplastic, and touching on the cutting-edge surgical and medical approaches used to manage them. The goal, as always with these deep dives, was to provide you with a shortcut, a concentrated dose of knowledge, to help you become really well informed about this incredibly vital region of the body. So, as a final thought for you, our listeners, to ponder. Given the sheer complexity and the absolutely vital functions we've explored within the thorax today, from breathing to circulation to protection, what single aspect of its design, or perhaps one of the challenges it faces, do you think best highlights the incredible, often unseen battles our bodies fight every single day just to keep us breathing and alive? And maybe, how does gaining this deeper understanding change your perspective on something as seemingly simple as automatic as taking your next deep breath?
That's a great question to leave people with. Perhaps for me, it's the humbling realization that even with all of modern medicine's incredible technologies and our rapidly expanding knowledge, our understanding is constantly evolving. It's driven by uncovering the very intricate details of anatomy, physiology, and disease that we've been discussing. The more we look, the more wonders and the more challenges we uncover. It constantly pushes the boundaries of what we thought was possible in preserving and restoring human health. And it definitely serves as a powerful reminder to never, ever take something as fundamental as a simple breath for granted.